My name is Jen Chapin. I'm the chapter speech language pathologist, assistive technology specialist, and I like to call myself the resident swallowologist. And it is my pleasure to introduce another talented speech language pathologist in our community. She'll be discussing the assessment and management of swallowing changes in ALS. Paige Nalipinski is a speech language pathologist that works in the speech language and swallowing disorders department at Mass General Hospital, and she's been there for 29 years. She's also an adjunct instructor in communication sciences and disorders at the MGH Institute of Health Professions in Boston. She's a senior clinician, and she specializes in neurogenic communication disorders, particularly ALS, primary progressive aphasia, which can co-occur with ALS, and dysarthria. She's a member of the MGH multidisciplinary ALS and neuromuscular team, and it is my pleasure to introduce and welcome Paige.
Good afternoon, everybody, and thank you for having me. When I was listening to Dr. Paganoni, the sound was in and out, and I went to a lot of rooms to see if the sound was best, where the sound was best. So if you're having any trouble hearing me, please let me know. But this is the best room I've got, so hopefully it'll sound okay. I'm going to share my screen with everybody, and hopefully here we go. All right, here we go.
I see that well, Paige. You're all good to go.
Good to go. Excellent. All right. I'm just going to minimize the people so I can see my screen. All right. So I'm going to be talking about the management of dysphagia, which is the word for swallowing disorders across the course of the disease. And I'm talking, I'm trying to use general terminology. If I touch on something that's unfamiliar to you, please let me know in the chat section. So what is normal swallowing? And when I'm talking about normal swallowing, I'm talking about in the non-ALS population or in the part of the population of ALS that does not have any swallowing problems. So let's see, I can't see part of my screen here, sorry. I'm going to actually unshare for 1 second and change the box. Oh, I don't, Well, I'm just going to do the best I can. I can't seem to maneuver that. I'm so sorry. All right. So first of all, a normal swallow means that you're able to take in food and liquids into the mouth without losing control of it. So without it spilling out anteriorly or without it getting away from you across the back of your tongue, causing you to choke. In normal swallowing, you're able to chew and move the food around. Munching the food, moving the bolus around, chew it. Sometimes people add liquids to it to make it more moist. And that means you've got to control a liquid and a solid simultaneously. If you're just liquid and flavor and the meat to send it down. So you intentionally can chew and you keep the whole bolus in the mouth until you're ready to swallow and it doesn't get away from you. Once you swallow, the mouth is cleared. There isn't residue on the tongue, on the roof of the mouth, in the corners of your mouth, or in your throat. You swallow and it goes all the way down. And this is all best case scenario. All of us have, issues now and then with swallowing, especially if we're distracted or if what we're eating is really hard to manage. And then swallowing without choking, coughing, or constantly clearing your throat. Those are all things we think of as a normal swallow. So when we talk about patients who have ALS and have swallowing difficulties, or even early before, or not everybody gets swallowing difficulties in ALS, but if we look at when I'm seeing a patient for the first time, we're looking at their normal eating habits, trying to confirm the normalcy of the swallowing. I want to alert clients if they're not having any trouble with me seeing them take sips or eating something or not complaining of any trouble. I want to alert them to what may occur. And there's this fine line between, not wanting to instill fear in people, but if we suspect because they're having some subtle speech changes or things like that, if we suspect something is coming, we want to about to minimize their risk of choking. And this also has to do with
I'm sorry to interrupt.
alerting them. There's some symptoms I'm going to talk about that can be really scary if you don't know what they are, but if you know and understand them, they're much less. Yeah.
Paige, we're having a hard time. Your audio is breaking up quite a bit. And your video is freezing too.
Okay. Thank you for letting me know. All right. I'm not sure what to do about that.
Paige, it might work if you just turn off your video. That might help lessen the amount of content going on your feed, and that might help a little bit.
Okay, so I'm going to zip through my slides real fast to just get out of here. Sorry, I'll come back to these. There we go. All right, so let me turn off the whole feed.
Just stop sharing your video. You'll continue screen sharing, but stop sharing the video.
Okay. So I just see it myself and you guys don't see it? Is that what you mean?
No, the other way around. We want to see your screen sharing, but you can stop sharing your video of yourself. See if that works.
Okay. Okay, does it seem better?
Let's give it a shot and see how it goes.
Okay, I'm so sorry. All right, so I'm going to go to the next. Where was I? Okay. So I was talking about letting clients know triggers that they can be aware of when they should seek help regarding swallowing. And we talk about those, and I'm going to review some of those in a moment. So early swallowing changes that we might expect to see. First is if the patient has difficulty with chewing more challenging foods, so starts to avoiding some foods like steak or sandwiches or things that are crunchy. People might be avoiding them or just saying, boy, you know, I had a salad for lunch, but I was so exhausted. Those are the kinds of things that are going to be really challenging for patients. The next we might see is patients complaining about coughing on water or other thin liquids, especially if they try and chug, if they take sips back to back. That's something we see as an early problem. Food sticking in the mouth, either on the roof of the mouth or in the sides and the cheeks. They find that when they're done eating, they've got to, use their finger to clear out any residue that's sitting in the mouth. Trouble taking pills. Swallowing pills is a very high level swallowing task. You've got a solid and a liquid, and you're trying to juggle the two, and you're trying to keep control of where the pill is in your mouth and make sure it doesn't get lost in the nooks and crannies or get away from you, while at the same time trying to manage a big sip of water to push that pill down. It's a challenging swallowing exercise. We notice that people, when they come to the clinic, if I watch them drink a glass of water, they're taking small single sips. They're not chugging anymore, where I might have seen them chugging on prior visits. And sometimes patients will complain of some gasping. So not a cough if water goes the wrong way, but kind of sounding like they're gasping for air. And they describe feeling like having a pinhole in their throat that they're breathing through. And this can be triggered by a crumb of food, a little drip of their own saliva, a bite of food, particularly if the food has a spicy, tart, or acidic base to it. Those tend to be things that trigger this gasping. But this gasping can also be triggered by things in the environment, like being around bleach or ammonia or something like that. And we're going to talk about what that gasping is in a minute. But that's one of the things that feels a lot scarier than it really is once you understand what's going on. So when I work with a client, I'm trying to assess, where they are within their swallowing difficulties, sort of staging my intervention based on what I'm seeing in the client. So help for early eating problems. For some patients, positional changes like using a chin tuck can be really helpful, although the chin tuck isn't appropriate or helpful for everyone. And this is one thing that people think it's across the board. Oh, just do a chin tuck and you'll be better. For some people, that really makes things more difficult. When you have a bite of food in your mouth, or let's say actually a sip of liquid in your mouth, if tucking your chin down helps to close your airway, but it also means that gravity pulls the liquid forward. And so it may be harder to keep it in your mouth. It may actually just fall out. So positioning can be helpful, but we help you to figure out the best position. Maintaining liquid intake is critical, or maintaining hydration. And we want to find a way for you to take in liquids, whether it's using a strategy like positioning or changing the consistency of the liquid you're taking, the amount you're taking in, or the vessel that you're taking it from. Some people do better with a wide brimmed cup. Some people do better with a little narrow sipping kind of cup. Some people do better with a straw. The next bullet, using a straw can be helpful for some people. A straw gets the liquid into your mouth more quickly and keeps it very centrally located in the mouth. So that can be helpful for sort of streamlining how the liquid comes in, and it keeps your chin in a naturally tucked position. But it also means the liquid comes in faster, which and further back in the mouth, which can overwhelm some people's swallowing mechanisms. So again, a straw as well can be helpful for some people and really not a good asset for other folks. And we need to kind of figure that out. Using 2 swallows per bite is a great way to help clear that residue, both in the oral cavity, but also the residue that can sit in your throat. As a good strategy early on for clearing the food out. What we don't like to see people doing, if possible, is washing foods down with liquids. For most of us who don't have any swallowing problems, if I have a little part of the pizza I ate sort of stuck in my throat, I'm not choking on it, but I feel it didn't go down completely, I can take a sip of water to wash it down. Again, having those 2 consistencies at once, kind of like with the pill, can overwhelm the system. So it's better to do a dry swallow, or be sure the food was moist enough in the first place to facilitate clearing the throat rather than following it with a sip of a thin liquid. Something thicker, like a sip of tomato juice or a sip of a smoothie or something, might be very helpful, but a thin liquid might make matters a little bit worse. And the last bullet here, it's great for the client and anybody in the household. It's good for all of us, for that matter, to learn choking first aid. What used to be called the Heimlich Maneuver, it's called chest thrusts now, but it's choking first aid, and it's something I've used it in my grocery store. I've used it at restaurants. I've used it on my son when he was a little boy. It's just a good thing to know. It really works, and it kind of puts everyone's mind at ease, knowing that they have sort of a plan if a large piece of food gets into the airway. That being said, everybody should be cutting their food plenty small, so this is not an issue. All right. Dietary consistency changes is a great way to help make chewing and swallowing easy. Painless, a way to change things up, starting with just softening the food. So either way, it's cooked, cooking things in a crock pot rather than on the stove, frying them, which might make them tougher or more dry. If you do it in a crock pot where you've got some extra juices and sauces, can really be helpful. Having things handy to make things that feel a little dry, softer, having an assortment of gravies, cranberry sauce, applesauce, chutney, things like that, that can make foods that feel a little dry or tough, softer and easier to manage. Maintain liquid intake. Again, staying hydrated just helps everything. But if you're having a tough time with thin liquids, thin things like water, coffee, tea, lemonade, things that are thin are harder to swallow because they go fast. They can get into any little nook or cranny if there's not a tight, full strength in your swallow, and they just can get away from you more easily. So if you add either a thickener like a gel or powder thickener to liquids, or take one of the myriad of naturally thick liquids, which really taste good. Again, tomato juice, mango juice, papaya juice, pineapple juice. There's many, many naturally thick liquids that taste delicious that go just enough more slowly than thin liquids to be swallowed much more easily. So that's a great way to get in that liquid that you need to stay hydrated. It's important to eat high calorie foods. I like to give the analogy, that you have a cup of strength in the muscles you use for talking and eating for the day. And we have to remember that talking uses up a lot of that muscle strength, but we want you to talk, of course. So you need to eat things that are worth the effort of the chewing and swallowing that you're doing. So every bite you put in your mouth should be calorie dense. Having a big bowl of romaine lettuce with a light Caesar dressing is a whole lot of work and not a lot of calories. So that probably isn't the most efficient and effective way for you to be eating. Having, if you're going to have something like a salad and you feel comfortable eating that, have lots of thick, rich dressing with it and some protein, piece of chicken or whatever you need for protein, but make sure you're not eating a lot of empty calories that are a whole lot of work. For some patients, it really helps to increase the sensory input of things you're eating and drinking. So making sure that things have a lot of taste to stimulate the brain to sort of make that swallow come as fast as possible. Or temperature, making things colder or nice and hot, not burning you obviously, but nice and hot so your body really knows something's coming. Or changing the texture. For some people, that may be making them really smooth, others a little crunchy at all is better, but thinking about what texture really helps you. I thought, what was it? Oh, I think with the increasing the taste, that is important, but it's also important to not get those things that are acidic or spicy if those tend to be things that trigger gasping sensation that I talked about earlier, which is called laryngospasm. Some high calorie ideas, things you can add to food that are sort of great for moistening the foods, but also can add lots of needed calories. Adding heavy cream or whipped cream to foods, adding nut butters, whether it's peanut butter, almond butter, cashew butter, those are all really good high calorie fats that peanut butter maybe not moisten things so much, but you want to have plenty of oil in them so they're not real dry. Adding avocado or guacamole to foods, sour cream, using things like full fat yogurt. You want to watch to not buy low fat or no fat things if at all possible, getting full fat items like yogurt and sour cream. And then pesto, anything like that that's got some fat and moisture in it is a great way to add calories and to moisten foods. Some snacks. So, some people find that eating 3 big meals a day can really be overwhelming. It's too much food at once and you get too tired. So one thing you can do is have 3 smaller meals and then have some real healthy snacks in between, but that aren't a lot of work and are lots of calories. So having smoothies, yogurt drinks. There are a lot of great pre-made yogurt drinks or like the kefir drinks that are great for getting some extra calories in. Having a bowl of a creamy soup, a cream of mushroom or a clam chowder or corn chowder or something. Having moist breads like a banana bread with butter, full on good old fashioned butter on it, makes it nice and moist, delicious, and a great high calorie snack. Things like hummus and guacamole are great snacks. Sometimes what can be hard is finding sort of the vessel for the hummus and guacamole, and having things like a soft piece of pita bread or a piece of a nice like a big mushroom where you can cut it in wedges and it's nice and soft to chew and a good way to sort of hold the hummus or guacamole. A raw carrot or a real crunchy cracker might be not the best idea because it's a lot of work and maybe harder. But if you can figure out something that you enjoy for dipping the hummus and guacamole. And then oatmeal. And you can throw so many wonderful things in oatmeal to make it taste great, be really good for you. But finding snacks is that you like that are good for you and in terms of calorie and fat is important. Rethinking your meals. This is one we are all so wed to. What is breakfast, lunch, and dinner? Breakfast is an omelet with some bacon and a cup of coffee, and dinner is a steak with a baked potato. And it may be that, or breakfast is a big bowl of oatmeal. It may be that it's good to sort of flip-flop your day. Who said you can't have pizza for breakfast when you're chewing your best? And who said you can't have a bowl of oatmeal or a milkshake for dinner? We've just got to get away from our traditional ideas of what makes a meal. So if you're better in the morning, have a big breakfast and or lunch, and then have something smaller and easier to manage at dinner. You want to be sure you get in those calories, but they can be any time during the day. For some people, it makes a lot more sense to have 6 small meals instead of 3 large ones. Again, it takes a lot less energy per sitting to choose 6 small things. I have some clients that say, you know, by dinner, they see a big plate of food and it's just so overwhelming, it kind of just takes away their hunger. They're not hungry anymore because they don't have the energy to face this whole plate of food. So having, you know, some of the items on the plate and not all of them may be more appetizing in a way. Looking at your plate of food, let's say we'll go to dinner. Let's say you have a steak and some mashed potatoes and a big pile of broccoli. Well, it may be that eating the mashed potatoes first, because it's the highest in calories, is going to make the most sense. If you think, I'm not going to be able to eat all of this, having the mashed potatoes with a few bites of steak and a few stems of the broccoli might be the way to attack the meal. And then if you have more room, great, eat the other things, but be sure, you know, don't start with a salad. Don't start with a big bowl of lettuce, and then you're out of energy for eating any of the things that are more high in calories. And then, as we talked about on the last slide, having some high calorie snacks between meals is a great way to supplement. Once we've sort of exhausted the possibilities of ways to manage the food, whether, you know, even if it's to the point of everything's going in the blender and making it smooth, and we've tried all of the possibilities in terms of how to change the liquids by making them thicker, by changing positioning, by changing the kind of cup we use, and we've looked at your swallow by using a video swallow study, which lets us see actually internally what's going on and helps us to make those decisions in an informed way. Some patients still might opt to get a feeding tube if you're not able to meet your calories by mouth. So this is when people would consider the insertion of a PEG or a G-tube. And there are really 3 reasons why folks consider a G-tube when they have ALS. The first is if they're having trouble, if their breathing scores are beginning to decline. So you might be eating fine, have no trouble chewing, swallowing, you're taking in 3 meals a day, 4 snacks, you're fine. But when the team at the clinic does your breathing tests, it's your forced vital capacity is beginning to drop. And if you're interested in a feeding tube, it's important that you have that procedure while your breathing will still support having that procedure. The surgeons usually have a sort of cutoff point where they're like, no, it's too dangerous to do that procedure now. So it's important to watch that score and time the procedure accordingly if you're interested in getting the tube or considering the tube. So again, that really isn't impacted by your ability to eat and drink at all. That's more has something to do with the breathing alone. A second reason folks might consider getting a feeding tube is if they're losing weight. And again, you might be breathing fine and you might be eating fine, but still that weight's just coming down. Some of our patients become hypermetabolic. Their metabolism just kicks into high gear. And makes them lose weight even though they're eating plenty. Their calorie needs just go up and up. And some people enjoy eating all day. Others would rather do things in addition to eating. So if it becomes this battle of, oh man, I'm just tired of eating all the time, I'm doing the best I can and I'm still losing weight, that's a time to consider the feeding tube. And the third is if you're having trouble swallowing. If every meal is a battle and we're trying together with the whole team working on keeping those lungs safe and healthy, and it's just not working, or it's so exhausting to work and do a strategy with every swallow you take, that might be the time to consider the tube. And of course, there can be a combination of any of these, but these are all the main reasons that patients with ALS consider feeding tubes. There are some things that are unexpected to patients that happen over the course of swallowing changes. And these are things that I like to bring up to people if I sort of see swallow changes coming, because again, they just don't necessarily in our minds connect with trouble swallowing. And I'm amazed at how many people in the first time I visit them, are you having any trouble swallowing? No. But then we get talking like, oh, well, I can't swallow pills anymore. Oh, I can't eat this. So our idea of what is swallowing, that's a very big question that may have lots of, subtleties in terms of the response. But these are the things that really don't pop into people's minds. So one thing that patients, especially patients who have spasticity in the system, so they tend to get the strained and strangled vocal quality, or when the doctor does the exam, they're hyperreflexive. The way that spasticity manifests itself in the swallow mechanism is the larynx, the voice box, which is at the top of the airway, doesn't function with the smoothness that it did before. It tends to get tight easily. So you get this strained, strangled vocal quality. I'm not great at imitating that, but people have heard it, this sort of tightness of sound. And the voice box, which is the top of the airway, can become hyperreflexive. The same way, if the doctor uses the mallet on your knee and you get a big kick reflex, the way the voice box responds to being spastic and having this hyper response is the vocal cords, if they are stimulated in any way, they slam together and that's when you get that gasping sound. Usually the vocal cords come together just for a second when you swallow and then they open again. But if they're in spasm, which can be triggered by, as I said earlier, acidic things, a sip of red wine, a little drip of toothpaste, or dust going the wrong way, something in the environment that your body sees noxious, like bleach, doesn't, again, not near your mouth. It can be across the room, somebody with a strong aftershave or perfume. Your voice box can go into this laryngospasm. It is a scary feeling, but it is not a blockage of your airway. It's not like you have a piece of steak sitting above your airway and you need the Heimlich maneuver. It is a response spasm that you can help relax by you relaxing. And I know it's hard to relax when you can't breathe, but if you have this sensation, if you're not already sitting down, kind of closing your eyes, trying to breathe in through your nose like a yoga breath, like a deep inhalation, and then out through pursed lips, just trying to relax your airway. Sometimes people say, well, it's so tight, I can't take a breath in through my nose. And if that happens, what you can do is just try and hum. It won't sound pretty because your vocal cords are very tight, but just trying to turn your voice on. It'll sound like a grinding, but all of a sudden that gets your vocal cords moving and you'll feel them kind of relax and you'll take a nice deep breath. You do not want to take anything to eat or drink when you're in laryngospasm, because that can just like adding fuel to the fire. You want to wait for a few minutes until you feel like everything has completely relaxed. But patients get really used to managing this or know how to avoid it. They know the triggers that tend to set it off. It can be triggered by just a little saliva going the wrong way, though. So it isn't always, things that you can control for. But knowing what it is, again, even if it's never happened, at least if you've heard about it before and it happens, you think, oh, this is what they're talking about. Yes, it's scary, but I can breathe through it. Some people feel like if they tip their chin way up to the sky and try and breathe, again, that's a position that opens your airway, that they feel some relaxation. There are different things you can learn to help facilitate this so it doesn't last as long. Another thing we can see, if patients have a weak soft palate, so that soft mushy part if I put my tongue behind my front teeth and roll it along the roof of my mouth, I'll feel a hard bony part and then a soft mushy part. And that soft mushy part is called the soft palate. And when we swallow, and for most of when we're talking, that muscle closes off the nose. Or for some sounds in talking, that muscle closes off the nose. And when that muscle is weak, if you take too big a sip and are trying to swallow too much at one time, that seal might give way and you may get water up your nose or whatever you're drinking up your nose. Generally, it's well controlled by taking smaller sips. When we go to swallow, we generate a lot of pressure in our mouth, and the thing that's in our mouth is going to go to the point of least resistance. So that's hopefully through the sphincter muscle that's at the top of our esophagus. But sometimes if things are weak near our airway and we get too big a sip, our risk of aspirating or having liquid go that way increases. If we get a big sip and we have weakness at the lips, it's probably happened to many of you. You take a sip, you go to swallow, and whoop, it just shoots out the front, out through your lips. Or the same thing can happen with your soft palate. That muscle just gives way and a little water goes up your nose. Very uncomfortable and not the way we want the liquid to go down. So reducing your sip size can help manage that. Excuse me one sec. A lot of clients complain of a period of time where they bite their cheeks or their tongue. As you have increased weakness in those bulbar muscles, the muscles we use for talking and swallowing, the tone of your cheeks and the tone of your tongue change so that they can be more in the way of your teeth. And it's extremely painful, and it prevents people from eating sometimes. It's so painful. If it happens, the one thing I've noticed, and this is purely anecdotal, this is not a research study on my part, but it tends to go away. I don't know if the brain sort of reacclimates to where the lips and tongue, or the cheeks and tongue and lips are sitting, but patients tend to have a period of whether it's weeks or months, and then it stops, even though they're still eating fine. But I think that one thing you can do to help reduce the pain, if you've been biting one of your cheeks, let's say my left cheek inside is all swollen, one thing you can do is when you're chewing, actually tip your head to that left side and kind of pull away your cheek if you're able to, so that you're not chomping down on that sore spot, giving it time to heal. A little harder with the tongue, but it hopefully will be a short-lived phenomenon. Positioning matters. Many folks, I've heard say, oh, well, I always have dinner sitting in my recliner chair, reclined while I watch the Wheel of Fortune. That's a hard position for eating because gravity is helping the food go back toward the throat, maybe faster than we want that to be happening. So while you're chewing, we don't want the food kind of spilling back before you intentionally want to swallow. So being upright when you eat, being again, the position where you can have a slight chin tuck or whatever postures are recommended by your speech pathologist. If you tend to eat sitting next to your roommate or spouse, get a place where you can sit across from each other so that while you're talking, you're not rotating your head to look at one another. The same thing if you're watching TV, you want it to be straight in front of you, and not too high up in the air so that you're not looking up at it, but looking straight ahead at it. But positioning does make a big difference. And taste and temperature, as I said earlier in an earlier slide, can really help facilitate the swallow. So eating really room temperature, bland food, to me, not only is that unappealing, but it really can make it a little harder for you to swallow because your brain isn't getting as much information. When you meet with a speech language pathologist in a clinic or your community, wherever you're intervening with them, there are a few things that the speech pathologist should be thinking. And I put this in the slides just so you know that this is kind of where our head is at. I'm really always trying to stay one step ahead of the disease and anticipating future needs. So though you may never have complained of that laryngospasm that I talked about, if I hear spasticity in the quality of your voice, I'm going to educate you about laryngospasm, not to scare you, but so that if it happens, and it's not quite as scary. If I notice that you're occasionally talking to me about, I drink water once in a while, I cough on it, then I might say, okay, let's slow down. Let's do one sip at a time, or try a straw. Let's try and prevent you from getting to the point where we have to put these strategies in place. If you're starting to lose weight, we'll talk about ways to increase the calorie count, the calorie density of what you're eating so that we can hopefully stave off that weight loss. I want to have a very clear idea about what your idea of quality of life is. And this may come through reading, if you have a palliative care doc on the team, it may come from reading their notes. It may come from discussions with nurses or the doctor, or I may ask the questions if I haven't gleaned it clearly by reviewing your chart. But it's especially important for me, are you considering having a feeding tube or not? Not that what I recommend necessarily would be different, but in the back of my head, I might, I'll just think about things trying to come from the perspective from which you're coming to make sure that we sort of have the same goal in mind. And with that being said, I need to be flexible and responsive to changes that I see in you and changes in attitude that you might have, and keep your attitudes and wishes foremost in my mind. This is about you and how you want to live your life and what you want to do with regard to, excuse me, what you're eating and drinking. You're the driver of the bus. I'm going to make recommendations to keep you safe, but you can choose to ignore them, and that is your choice. I want to make sure, though, that you're 100% educated as to what your choice means in the long run. That's my goal, and my job is to make sure you have the information to make the choices you do. And I need to remember that your attitudes and wishes can change along the way. You may, the first 3 meetings we're together where you're really not having many difficulties swallowing at all, you may say, yeah, no, I don't ever want a feeding tube. That's something I don't want. By our 4th visit, you're having a little bit of trouble swallowing, and you think, oh, you know what? Let's talk about it. Educate me. I need to know that that's okay. You need to know that I think it's fine that you change your idea and your wishes along the way. And we will take this journey together, and I will give you any information you need to help you make your choices. And I'll keep an eye on how things are going, but we're in this together. And I want to help support you and your family. All right. So I hope that things worked better when I turned off my camera.
They did. Thanks, Paige, so much. I appreciate that talk. And, it's always so nice to listen to another speech pathologist speak and hear them say so many things that are similar to what I say. It's very validating. So thank you. Sure. We're on the same page. It's a good thing. So we have a few questions here in the chat box that I'm going to assist with. I'll read those aloud as I see them, and Paige, have you tackle those. The first one comes from Mary. She wanted to know, how might someone modify the Heimlich Maneuver for someone who has an infusion port in their chest, or do you need to modify that?
That's a great question. I wouldn't think so, because the Heimlich Maneuver is low down. It's down, right above the belly button, basically. But I've never heard anything that speaks to it being contraindicated with somebody with a port, unless your port is in a very odd place from what I'm used to. But it's a great question, and one that you could certainly ask your nurse or doctor. But I wouldn't think it would be contraindicated if it's just the normal Heimlich Maneuver in the normal spot. And
I think, that port can be replaced. And the emergent situation is a choking event. And so you got to take care of that first. And if something happens to the port, you address that next. But
exactly. That as well. But the port, usually I've always seen them much higher up. And the Heimlich Maneuver, we are not licensed to train to do that, but I think you can actually even do an online training now. It's very simple. It really works. So you can go to the American Red Cross website, and I think they have a video for educating you on that. I recommend, it's always more challenging if somebody is in a wheelchair or something like that. But getting them flat so that you can do the maneuver, or out of the chair to a Dover chair, makes it a little more complicated. But you can even learn to do it on yourself. They'll tell you to find a chair in your house that's the right height, so you kind of know the go-to chair if you need to do it on your own. So I think it's great for everybody to know how to do that, ALS or not. It's just it works. So
I echo that. I give those recommendations out similarly to the folks in our chapter. And my message is always, I hope you never need it, but if you do, you've had the training. Yeah. So it's always better to go through the training and never have to use it than to need it and not have the training. So
it gives you peace of mind. I think you kind of feel like you know what to do in that situation.
Yeah. Next question from Callie. Is it beneficial for patients that exclusively use a feeding tube for meals and fluids to do swallowing exercises to keep muscles as strong as possible?
So my feeling is no. I think, even if you're not taking anything by mouth, you're still managing your saliva and your secretions. And that is probably all the muscles can handle. We want your muscles to stay strong enough to do that as much as they can. And trying to just do exercises for the sake of keeping those muscles strong may make it harder for you to manage your secretions. And that's going to give you a lot more trouble. So I would say no. Would you agree, Jen?
I would absolutely agree with that. I think there is a place for exercise in ALS, but that place is very early in the disease course. Yeah. I think looking at exercise, physiology and muscle physiology studies, muscles have to be able to recover from exercise. And in ALS, when muscles are significantly affected because the nerve impulse from the brain just isn't getting there anymore, they really have a hard time rebounding from exercise. So it becomes damaging, not helpful, in muscles that are severely affected like that. So I completely agree.
And I anytime I have a new patient, that's of course the first thing, like, what can I do? What exercises can I do? If I'm seeing any changes in the speech or swallowing, none, because again, you're already to the point where there is enough damage to those muscles and those signals that it's going to be really hard to recover. That's why during the course of the day, you feel more and more fatigued. Your speech sounds worse. The chewing gets harder because those muscles can't even recover from the things you already are doing. Mm-hmm. Doing a lot of exercise that's really not going to gain you any strength is just going to fatigue you faster.
And quite frankly, you don't use very much strength per se when you talk.
Right.
It's more of an agility task. It's not,
right.
So doing strengthening exercises for poor agility doesn't make sense from an exercise standpoint.
Yep.
All right, next question. Oh, that one's from me, so I'll leave that. Let's see. How does one deal with oral care? Oh, this is near and dear to my heart. So Pauline, thank you for this setup. How does one deal with oral care? Any tips or tools to help clean the teeth?
Yeah, so oral care is critical, even if you're not eating and drinking, or maybe especially if you're not eating and drinking, because what we're trying to do is keep your lungs. Of course, we want to keep your teeth and your mouth healthy, but ultimately, when I think about oral care, it's keeping your lungs healthy as well. Because if you have a tongue that is encrusted in bacteria, and your secretions are mixing with that bacteria, and you have trouble swallowing your secretions, they go the wrong way, then you're bringing a lot of potentially infective material to your lungs through your saliva. There are lots of different, anything from an electric toothbrush to a water pick to a tongue scrapers. Mouthwash is a hard one for a lot of our clients because we don't want you to aspirate the mouthwash. But depending on your hand and arm agility, the people who are helping you, it's very important, but it may be different from client to client. Toothpaste is one of the things that with a lot of patients can trigger that laryngospasm I was talking about. If a little, just teeny bit gets even in your throat, not near your airway, can trigger laryngospasm. So I sometimes recommend using a pediatric toothpaste because it doesn't have that sort of that sharpness to it. It's more sweet, but it doesn't have that same sort of triggering effect. Using a tiny bit of toothpaste is the other thing. You don't need a whole toothbrush full. I don't know, there are a million tricks, but it can be challenging for sure, but it's really important. Any tricks off the top of your head, Jen, that are your favorite?
Oh, I'm a huge fan of a 3-sided toothbrush. So for endurance, and they have electric ones. I also, for caregivers, because Pauline added anything that we could suggest to deal with oral care by a caregiver. And I would say, yeah, I'm a big fan of mouth props. They're like soft foam types. They're about a half inch to an inch that you can place in between the molars on one side of the mouth to help the jaw rest on it. So you brush the other side of your loved one's teeth, and then they can just rest their jaw and not have to work to keep it open. Mm-hmm. Or if their jaw wants to reflexively shut a little bit, it's really helpful to have that in there. So I'm a big fan of that too. Paige, I'm going to ask you this next question, and then I have to get my computer charger because my computer is going to die. So I'm going to ask you that question, and then I'm going to skedaddle real quick and let you go. But the question is actually from me because I've struggled with this in my career. But have you found anything that helps people with biting their cheeks and tongue? Or I've seen a hyperactive jaw jerk reflex or a bite reflex where the jaw just snaps shut. And if the tongue happens to be in there, you're in trouble.
Yep.
Have you found anything? And I'll be right back.
Yeah, drop a bomb and leave, Jen. Go ahead. No, unfortunately, this is something a lot of people struggle with, especially when they have, spasticity in the system. They can get what we call trismus, a tight jaw, clenching, biting. It can become painful to some people. I've had patients who have gotten Botox to help with relaxing the jaw and the muscles. The things like bite guards, sometimes those stimulates salivation so much that it makes they get just a lot more saliva in their mouth, and then they're juggling with the secretions. This is something we've looked at so much, and there are not great answers. It's a hard one. and that like the sneezing and yawning with the coming back down and clunking on your tongue, or you're knocking your teeth. I've had patients who have chipped teeth because they slam their teeth together. It's again, it's this hyper-reflexive thing, and we haven't found, at least I have not heard of anything, a great device to help. With some of the mouth guard things, they may keep your teeth a little bit so your teeth don't chomp together, but again, the saliva they produce becomes a huge problem.
Yeah, that
hurts to acclimate to them. I mean, I know when I've tried to use a night guard, it took me weeks and weeks and weeks to stop producing so much saliva. And I can manage my saliva, so it's a real problem for patients who have trouble managing their saliva.
Yeah, that's pretty much my experience too. But I keep asking the question because I keep hoping someone's going to give me an answer where they've found some trick that's actually going to work for them. I got one private message here, but I want to ask you that. So a gentleman asked me, what about the Hammock Maneuver with the feeding tube?
So another great question. Again, I think where it is low enough. It should be quite below where, so usually the feeding tube goes in. The Heimlich is given, so if you feel like where your ribs end, the Heimlich is done right below where the ribs end. So up higher than most people get their G-tube. I know G-tube placement can be a bit different from client to client. But again, I think if it's an emergency, if you're going to die if you don't get the Heimlich, you can always have a new G-tube put in. That's a pretty easy procedure. And that's much less sort of difficult and risky than port placement in terms of infection things. So I would definitely say do the Heimlich.
I agree. Another person mentioned, Beth mentioned that her dentist found a sharp place on a tooth that he filed down, and it decreased the injury from biting her tongue. So that's interesting too. But I think if you're having that problem, and Paige, you can speak to this too, but I think if you're having that problem, I think a dentist is a really good person to talk to about. They may have ideas that.
I had a person who had a really sharp tooth who used, got the sort of wax that an orthodontist gives kids to put on the metal parts when they're new because it irritates the kids, that when they between meals put this like a little hunk of wax on that sharp part of the tooth. But filing it down, if it's somewhere that they can do that, I agree. Talking to the dentist about problem places, if it persists. I've really found that most people that biting, it is for a sort of a finite period of time. And again, I don't know if the brain sort of reacclimates or what, but usually it's not a long, ongoing, forever type of thing.
Mm-hmm. Yeah, I think it's just when it's caused a lot of damage one time. I mean, I've had some people that really almost bit through their tongue.
Yeah.
And sometimes that, as you know, that spasm will last for a while. So, not just real quick, but that spasm can last for 20, 30 seconds, if not longer. And that can be really, really hard to get to relax out. So yeah, that's been one of the big challenges. How do you go to the dentist when you're stuck in a wheelchair?
So I think what you need to do is find the right dentist. Again, I'm not making a plug for MGH, and I'm sure there are many others, but Mass General has a dental clinic that has places where people come in their wheelchairs and they're used to doing the work with the patients not as reclined if they can't recline because they're going to choke on the secretions. There are dental offices that are used to working with patients with serious illnesses, and you need to find one of those so that they can accommodate what you need. And they are out there. But they tend to be more in the cities and either not necessarily at dental schools, but at hospital dental clinics sometimes I've found to be the best.